Good morning. Today we are going to talk on the intermediary fixation principle. Now you know means what is the basic principle between intermediary and plate fixation? It is weight bearing or weight sharing? Weight sharing. What is the best? What do you understand by weight sharing? Means is also beardy weight shared by the bone and it. On the other hand, in case of plate weight bearing means what? That means entire body weight is being transmitted through the implants. So implants may get failed. That is the basic principle. There are two types of actually fixation most of the time we do encounter. One is intermediately, one is shaft on the surface. One is intermediately, another is on the surface. Both the principles are a bit different. One is weight bearing, another is weight sharing. So necessarily in case of your middle fixation, it is a weight sharing. So you share the weight. So in this case, we know means one of the person who has got immense contributions in the field of intermediate fixation is your Kenneth. K means Kunzert. Graham Kunzert is from Germany. Around 40. At that era, he started doing the intermediate fixation. That is also entry grade. Not entry grade. But what is the little bit of the KNL is supposed to know basic principle of intermediate fixation. Let the nail is your clover sepet in cross section. It has got two eyes. One cleft is there. The principles of your is intermediate fixation. You must understand certain things. It has got limitation. Yes, this but this was the basis of your intermediate fixation most of the time. It is very advanced. Then first generation, second generation, third generation is coming up. Basic is coming from this net. So even today also in certain situations where you are unable to do the intermediate fixation, probably you have to go back to the chemistry. Even today also in certain situations where this facilities is not available, people are doing this. And ideally, if there is a fracture in transverse fracture in subtrochanteric area, upper one third, then this is one of the ideal fixation. It's much area, transverse fracture. Even today people used to do. Yes? Okay. Now, sometimes in examination, examiner may ask you about this, your canal. Little bit of canal. What is the limitation? What are the functions? How is a 3-point fixation? Basically, this principle of fixation, 3-point fixation. 3-point means your one point is here, another point is here, another point which is in touch. 3-point fixation. That is the basic principle. Now, sometimes they ask you what is the importance of this slot. You know, slot. What is the importance? Compression, little bit of compression. It also helps in neovascularization. Our most important thing, mechanically it gives support to what? How? So while inserting, where you want to place this slot? Anterior. Yes, correct. If you look at the femur, you find that there is a board here. And you know, we want to fix or counteract the deforming force working in tensile surface. Yes, whatever you implants, you know the basic principles in fixation that we supposed to neutralize the deforming force working on the tensile surface, not on the compressive surface. This is a basic principle. Same principle is applicable here also. So necessarily when there is a bend here, the force of the muscles will also try to exaggerate it. Now in these situations, it is ideal to place the slot in this area so as to counteract. It is said that if you try to bend it here, the resistance is more than this. So this side you can bend it, but here you cannot. So you have to place this slot like this. So mechanically it is going to help you. Most of the time we used to do retrograde technique. Retrograde means open up. Do the reaming, then you pass the nail like this. You know, basic principle in certain situations, suppose you are unable to do it, you may need to go back to do it. Somebody everything fails, your CM is failed, or something happened wrong with the intermediate fixation, though it is tried, but failed. So probably you have to go back to this. So there is a need to keep this nail in your armamentarium so as to save you in certain situations. So that is why basic principle is supposed to understand. That this is open technique. This is not a closed technique. Open technique, what is the exposure, Anterolateral, lateral, posterolateral. No, you are wrong. No bhasa. What is this? one lateral exposure, anterolateral exposure. Anybody know it? Where put the incision, what it will do? One technique is that lateral exposure, you go through the muscle. That is what? What muscle you are splitting? Ideally should not be done. You try to strip up. Strip up from where? From where? Lateral muscular system. Very good. So you know many open technique, you have this lateral word, you have the anterior muscles, you have the lateral muscles. Here you have this lateral intermuscular septum, where you have the origins of the vastus lateralis also. So in these situations, you need to strip up this your origin of the muscle from the anterior lateral muscular system. Got my point? Strip up. So that you are not injuring the muscles. So if you do injury, there is a technique people used to do, but there is a damage to the muscles. So that this is a fibrosis and a problem here. So do not want to do the damage. But what important structure come in between? It is the perforators. So you have to be very careful in this situation. Sometimes perforator may come in. If the perforator is torn, it is very bad because it is retracted behind the lateral intermuscular septum and it becomes very difficult situations to continue. So you have to be able to identify this, then cauterize it, then go ahead. So it is a intramuscular exposure. Money in between the muscles, not through the muscles. So simple technique, open up, then you have to identify, then do your lifting up, then doing the rimming. How do you start the rimming in case of retrograde technique? This is retrograde technique for tennis. That's simple thing I am talking about. You sometimes may need to go for, though you always try to do for intermediate fixation by IL close tennis. But certain situations you may need it. So you have to know basic thing. Patient is lateral position. Incision is made. Vastus lateralis, the fascia is cut. Then vascularity you will take it anteriorly. Strip of the muscles from the anterior respective lateral intermuscular septum. Now you can put the lever, then you are in between. So posteriorly you have a strip. Be careful that you are not injuring the your perforators. Now hold it, then you do it. Now at the position of time, how you do the what is the position of the limb? How do you keep the limb? One is adduction, another is flexion. If you do so, then it becomes more supportive. What is the meaning? If the patient is there, patient is lying like this, if you do more adduction, it becomes more superficial. Yes or no? Adduction, superficial. So it becomes easy to take it up. And little bit of flexion. So if you do the flexion, adduction and pass the reamer, you will find it is injuring less muscles of the gluteus. That is why you do the flexion and adduction. Okay? Now you do the remaining everything. So it is a retrograde technique. Retrograde means you have now open up. So rimming is important. Then you have to go one by one, 9, 10, sometimes 11. Yes, one here. Another is also this side. Do the rimming first, then put the nail. So how do you place the nail now? So patient is lying this, the lateral position. Now limb is flexion. মানে ফ্লেক্সন হলে কি হবে এটো ফ্লেক্স হবে না আর রিডাকশন সো it become more superficial. So you have to pass the nail like this, and the placement of the nail, as I said, it is anterolateral. So you put it like this. Before that you have to take the measurement of the length. That is beforehand. Before that you can do it. There are certain techniques, and also intermediate you can do it. Intraoperatively also you have to determine the length. Length is that the length, you know, superior pole of the patella. Then you keep this eye out. So the length is a bit more. So you want to keep it outside. Why it is important? Important to extraction. Otherwise it will be difficult. If it is submerged there, particularly in case of children, if it is submerged, then you need to do osteotomy to remove the nail. So that is why it better to keep half inch out. Okay? Now, then you have to go back and do the alignment and fixation is there. What is the limitation of the nail? That you see this nail is there, so it is not going like this. It is holding it. One point is the rotational instability. That rotational instability is addressed by whom? Interlocking device. How it is coming into the field? Kunzas has given this. Same Germany again has given us this this technique again in 1970 by Josie Campbell, GM. They are also from Germany. So Germany was the person who has given us this gift, and they also introduced the technique of interlocking. So that problem is that because it was in rotatory instability was to be addressed. So that is why they are coming with this technique. That is around 1970 this technique was introduced. Nowadays it is the gold standard technique for not only for the femur but also other intermediate, particularly long bone. Today's concept is that most of the difacial fracture of the long bone is being addressed by intermediate fixation. But metafacial fractures are different, where you have nowadays very specific plates available, so you can address it better. But even people are trying to do expert nail or other modification of nail so as to address that part also. So this nail is also being coming up first generation, second generation like this. Now let us come to this nail. Now first generation nail and second generation. Do you know what is third generation? First generation and second generation. First generation nail is that it is interlocking nail is going through the lesser trochanter level, and another is going above. So this part is not very ideal. Second generation nail you find it is PFN, where the internal squeeze is going to the nail. First generation, second generation, modification. Nowadays again newer things are coming up. First generation, second generation. Now we are now going for the intermediate fixation. Now what is the technique? Now what is the ideal time to go for the fixation? In case of open technique, it should be delayed. It is said that this injury itself is causing extensive injury. Again, top of this surgery also doing more damage, and there is a concept. This is called avascularity of the end. So it helps in revascularization, and also it reduces the inflammation and edema. Other things are there. So that is why open technique is being delayed, but closed technique can be do earlier. The concept of your fat embolism and other things are there. There is a controversy in this context whether to go earlier. There is no substantial proof that it is the cause, but ideally it is said if the patient is coming with chest injury, it is better not to do the rimming. So rimming is it. So we are more concerned about the rimming. So rimming may lead to displacement of the intermediate fat and go to circulation for the everywhere. So that is a problem is there, but it is not substantially proved that it is the cause. But it is ideal not to do the rimming in the case of the chest injury patient. If the patient is coming with chest injury, refracture is there, better not to do the rimming. A time frame is a bit controversial. Interlocking when to be done early. Open techniques should be done better today. It is said by the second. Causes are there. Now, patient is in supine position or lateral position, both conditions. Patient can be done in the supine position as well as lateral position in fracture table. Now it is in traction. People used to go sometime even your traction is skeletal suffice. People used to go. You may not need to do sometime. If it is late, things are different. Now, how will you proceed? How will you proceed? Entry point first. So how do you find out the entry point? How do you find out the entry point? The patient is there in the supine position. It can be done in lateral position also. Particularly happy men is better to do lateral position. People are doing it. But we are more convergent of doing in the supine position. Now if patient is supine position, reduction is being done, shear is done. Now our aim is to go for the entry point. Now how do you find out the entry point?
Sir, you drop a perpendicular from the sides. You drop a perpendicular from A sides and you extend a line from the side. Going through the
incision. Regarding the incision, there are two things. One, where PFing is being done, 10, 1.
Then
Number 2, intermediate fixation. Then where you should put incision. BFN is going to toward you more because it is like this. But it is long axis, so it is go toward the iliac crest. So if you do the iliac crest, the axis is square. But one thing take care for the injury of the soft tissue. But ideally it is said that the incision should be more proximal in case of your intermediate fixation where on axis. If it is off axis means you are going for lateral side, so it is more distal. So it is the anterior spine, dotted line, midpoint of this area is the area for the broken entry. Okay, but here you go for proximally where you get this side, so that the axis is almost straight. Axis is almost straight. Got my point? So it is more proximal, it is distal. Here, now you are doing the incision, you have to split the muscles, go up to this. Now how to find out the entry point? What is the entry point? Entry point is the peripheral fossa. So if you, what is the muscle inserted there? Obturator externus. Obturator externus. So if you take this transverse diameter like this, well ideally supposing this is the correct, he is right. So if you have 3 half, so you supposed to go posteriorly or anteriorly? Posteriorly. 2/3 is above. Got my point? So necessarily your entry point is somewhere here. Okay? Now if you take this entry point here, if you take the AP view, what is the relation? Relation you will find overlapping of the superior bone. This overlapping indicates that you are in right track. Got my point? So now whether your entry point is right or wrong, the AP view also gives the indication. So if your point is lying like this, you are more to the outside. Now the X-ray what you are talking AP view, there is no overlapping. There is no overlapping. Got my point? So if there is overlapping, you are good. If it is no overlapping, you are not good. Got my point? So AP view, you have to confirm the entry point, both the AP view and lateral view. So if you take the lateral view, you can have an idea. One can have a feeling also that I supposed to be like this. And AP view will give the indication that I am in the right track because there is overlapping of the superior border of the neck. No overlapping means you are more anterior. We want to be more posterior. If you take the 3 halves, 2 halves should be above, 1 half should be above. It is junction point. So entry point is about 13. Now you have various types of ovals. Oval answer no oval. You have various types of ovals. So the ovals are a bit diamond ovals are a bit different from the tibia, and also for femur. Femur is almost only straight. That also you can come in 2 ways. One with a hole, another without hole. The hole make your life more easy because through the hole you can pass it. Okay? Now point is something important here. Suppose the fragment is more posterior in the proximally, and your entry point is like this, you have to be careful. Why? The alignment. So one thing is there, supposing the fragment is somewhere here, you want to do intermediate, it can be accepted. Now what is happening? Fragment is like this, right? Fragment is like this. Now your entry point is like, so if the fragment is lying like this, your entry point will be like this. If you are not maintaining the axis, you are probably going posterior. This is very important. Sometimes it makes your life very difficult. So at this point of time, it is better to have a reduction. Now what are the reduction technique? Reduction. Sometimes it is better to have a reduction before entering. So you are make the life more easier. I got my point because of the forceful muscle working over it makes the difference. Now the entry point is decided on the basis of the normal element. Now because of this forceful muscle attachment, the anatomy is distorted, axis is different, your axis support. Got my point? So the fragment is lying anteriorly. Now there is a flexor muscles going like this. Fragment is like this. At this moment of time, you will find fragment is like this. Now your entry point is like, okay, entry point accepted. But what about the axis? You are not correcting it. So it will go posteriorly. Got my point? It happens. Okay, so better to your, so that this entry point is designed on the basis of the normal axis, not on the seg axis. So you try to bring the fragment to the normal axis. Clear? नहीं तो जिंदगी तो कभी कभी बहुत दिक्कत हो जाता है. Sometimes you will go posteriorly and it will be, once you are going wrong track, it is very difficult to go back to the position. You have to struggle a lot. You have to struggle a lot to correct it. So that is why entry point is one. Once the guide, then a bhul bole ya guide. If the guide is going wrong, then all the people are going wrong. So here is a technique. If your track is wrong, then everything will be wrong. So your track is always. So the entry point is a D point. So I need to put the entry point correct. If the entry point is not good, you will have to struggle a lot. So that is a practical here. So in your life, you try to. So I suggest you to do a little bit of reduction. Not may not be, but alignment should be maintained. So that your life will be easy. In these situations, what are the techniques by which you can do the reduction? Reduction is necessary for the guider to pass. But beforehand, do you know what are the techniques, how you can do it? So if the fracture is here in distal part, what should be position of the distal fragment? It is go mostly the posterior because the posterior muscle attachment of the gastrocnemius. So you must have an idea that distal fragment means it is going down. So what you need to correct? You have to lift it down. 1 point. Now if the proximally fracture is there, you will have to have a correct. No struggling. Then you know the fragment is going like this. So this sort of mentality of fixer should be. Middle fragment it may go this way, that way, depending upon the fracture configuration and morphology of the fracture also. But what are the techniques? One is the manual technique, what you are doing. One. Number two, sometimes the steps can be applied. Even bed sheet or other, you can apply to pull the axis. Number two. Number two, do you know any F-shaped device? F-shaped device is that F. This one edge, one head. This F is very important. No. I have not learned, I tell you. This is one thing you can yourself also make it. It should be radiolucent, even you can wooden also can help you. Radiolucent. It should be radiolucent. So if the F is, so F. Okay, now how will you place here? Suppose the fragment is going up, this fragment is going down. What I am going to do, I put the line like this and this line like this. So if you like this, so it will be pushed, it will be cut. Got my point? Because step sometimes make your life easy. You may not need more assistance. This is going to do the liver section. Got my point? Yes or no? So if fragment is going like this, another fragment is like this. Got my point? Now you do the F like this and do it like this. So it will correct it. So it sometimes make your life more easy. It should be radiolucent so that you can do leverage without much force. Because if the lever is wrong, you can do less force to correct it. Correct? You do not need to struggle on. It is a simple technique, one can make it also with a subnormal radiolucent, particularly wooden. So that is one point. Any more technique? Sometimes even if you can go for your statement pin or even your sense screw, so that to do a joystick sort of thing. Yeah, another technique without opening up. And finally, if everything fails to reduce it, go for mini exposure. So these are the techniques. So reduction, I try to do close. Principle is that you do not want to open the fracture side. But for doing this, there are various techniques. Manual manipulation depending on the fracture positions is the commonly practiced technique. On top of this, we can go for the F-shaped device which can help you to leverage it very easily with less force. Yes? Finally, if it fails, you can go for the joystick technique. Sometimes one cortex is being pinched with the help of your external statement pin or your sense screw. Then that can be leveraged to help you reduction. And finally, everything fails, you can for mini exposure and go for leverage techniques to open it. But you have to have a reduction. So these are the reduction technique for your headache. And you have a mental tap for this fragment will go like this. And this fragment, because of the adductor muscles, may go like this. So this sort of your picture should be in your mind. So you need to do that. Okay. Now we have done. Diamond oil is being used. So diamond oil do what thing? They do the continuations with the medullary cavity. It is said that intermedullary pressure is maximum while you are putting the diamond oil, not the rimming. Very sorry, no? Not the rimming technique. Rimming technique also, yes, it increases the intermedullary pressure. But it is said that the maximum is being generated by the diamond oil. Initial stage. It is a closed chamber, if you are pushing it, it will then. That is it. Oil. Oil's technique is going to generate the maximum intermedullary pressure. A2 needed. What do you want to do? I want to align this fracture. So, for passing the guide wire and also doing the nailing technique, I must achieve a reduction. For this, we have to practice various techniques. Simple techniques by manipulation. What about by doing? You have to design where is the fragment. Fragment is going medially, you have to bring in laterally. With the help of your event, sometimes you can take the help of a Prof also, pull it this way, that way. You can take the help of the F. F you can like this, if the fragment is going like this fragment is going like this. So I will put the F like this and I will do it. Yes, now fragment is like this. Another fragment like this, I will put the lever like this and do the correction with the help of F. With the help of F device. F device is very easy technique, so one can do it. Actually, we are supposed to practice it. It's supposed to be resolution so that it doesn't interfere. Got my point? If it fails, you go for the various techniques. Sometimes 10-min pin technique, or even you can joystick technique. Sometimes mini exposure to the leverage. After all, you have to have a reduction. So these are the basic. You have to go like this. If everything fails, you have to open up the exercise and also the but reduction, without doing reduction, you cannot further progress. One point is the entry point, and next point is the reduction. So once doing the reduction, you are passing the guide wire. Guide wire. Okay, this is the guide wire. So what should be guide wire? You know there are two types. One is your with ball tube, another is your ball tube. Ball tube with some angulation helps you to do the reduction and negotiation. That is one. One point. Okay? So I am putting guide wire. Where I supposed to put the end point? End point supposed to land at the subcondylar bone. One point. Number two, it should be central in APV and central lateral view. So you have to negotiate like this. Sometimes we may bring the fragment like this, that whatever it may be. But after all, your landing point is the central view and central lateral view. How do you know the pure lateral view? Overlapping. It should be overlapping of the contact. Two views are there. Got my point? So it will be clear. So landing point. Then next is the rimming. Rimming there are two. One is manual rimming, another is a flexible rimming. So one point you are supposed to start at, you do the rimming only after a while entering the medullary cavity. Got my point? Do not start the rimming beforehand, because a lot of them is to be surprised. You have to enter there. Initial one is the fixed one. One is end cutting and the side cutting. End cutting is going to track it. Side cutting is to enlarge the body. And then where you need to stop, these are techniques. You have to go very carefully there. If you are using flexible, then you have to have a what? Knob. So if you want to do manual limbing, probably you don't need the lock. So if you have with the knob, you are using guide wire, then you have to exchange it. Exchange. Got my point? Yes. Otherwise it will be difficult to negotiate with the snake. If you are using flexible, then you have one step more. So you are putting it. Rimming should be done from the smaller to bigger size. One point. And techniques. So do not stop rimming in the between. If you stop, you are stuck. Particularly flexible. So go steadily. If you are doing to and fro, movement can be done. If it is stuck, and sound is very important to understand that how this sound, stuttering sound is very important. If it is stuttered, then you know it is a limit. And what do you do with the comminuted fracture? We do not do the rimming at the area. We want to push it. So if there is a combination here, so what is the important thing? Important in landing here, but reduction you don't know. That you have to align the fragment with the help of your what? How do you know that my reduction is okay? Reduction is okay. There are certain things. Thickness, correct, very good. If the rotation, So you know, so then problem is that if there is a transverse flexure or oblique flexure, one can have a reduction and can be confirmed with the Siam. Or what about the committed flexure? We do not have that sort of anatomical flexure. But what is more important to understand that I do not want to have any rotation for me. So rotation technique, they should be corrected. So you have to take the help of the other clinical things. What we do practice here. Got my point? In the case of a transverse flexure, things are different. Committed flexure, things are different. So committed flexure is supposed to look for the thickness of the cortex in the Siam. So the my cortex is okay. You go to reduction. Again, clinical other points are there. What is the position of the patella? What is the position of the foot? Even you can take the axis of your Siam with the help of your pottery rod. Now, however might be, in case of committed flexure, you have to be more careful so that I do not do any angulation in rotation. Do not do any angulation. For this, these are the points. Okay, so landing of the point is very important, wherever landing. And doing the rimming, I showed you 2 points, at least 2-3 points. One, entry point, enter, then doing the rimming, not beforehand. Enter, then start doing, and go gradually. Sound is very important. Sometimes you may need to do some sort of manipulation at time, because the fragment being set down or go this way, that way for distal fragment, because you are putting on the guide rail. So guide rail cannot hold you. Sometimes you do need to, so that to negotiate it. Got my point? If you are otherwise stuck on the end, at the end, flexor end of the distal fragment. So, one. Then do not stop the rimming in between. This is very important. So you go 2 and 4. You can go 2 and 4 movement, go steadily, come back, go again, come back. Stop it, you may stuck. Do not try to reverse it. The uncoiling, flexible limb are very dangerous. It is easy and dangerous. If it uncoiling is taking place, it will be a hell of a lot of problem. So uncoiling, do not do the reverse thing. Always it is going like this. We doing whatever it might be, it is always in right clockwise, not anti-clockwise. No movement anti-clockwise. You have this flexor device, I mean to say gun, your drill systems with reverse technique also. So do not apply this reverse technique here. If your reverse technique is applied here, it will uncoil. Uncoiling will have a problem. So do not do reverse. Entry point 1, rimming, go by go up to the end. Do not do the rimming, the flexor side, this commuted flexor. So you push it and go back again to start it. Okay, sir? So one time will come when you have to stop. And what is the time? Time is certain. This sounds is it. So you are cutting more bone means you are this good for the stability point of view. Bigger the size, better the stability. So there is a hell of a lot of your difference between 9 and 11. You go in the textbook and find what is the difference between the stability of 9 mm and 11 mm. There is a huge difference. So it implies that bigger is the better. But it doesn't mean that you have to cut the normal bone to do it. If you are cutting, you are damaging the normal bone also. So they have a limitation. The sound is going to limit you. Okay, sir? So what should be size and nail of the rimmer? So rimmer should be 1.5 to 2. Sometimes even 1.5 to 2. 1.5 to 2. Then that of your nail size. Got my point? 12 or 11 jabo. 12.5 or 11. The 1.5 to 2 like I said is one. But 1 is best. 1 to 2. 1 to 2. Size. Difference between the nail and the hair. So now if you have applied the guide wear, then I have to do the exchange. Exchange technique, you know what is the exchange technique? So you have to plastic strip to introduce. Sometimes this plastic tip, there is a metal there which is going to give a resolution the way the tip. Sometimes it is very difficult to do. So rotatory movement is important to push it. Otherwise, ends sometimes do not go enter to the distal fragment. So if you do the rotatory movement go, but whether you have passed it or not, it cannot be seen in the X-ray because these are resolution part, plastic one. But the tip there is sometimes metal set here. So that is going to help you to guide the iron here or the function. Got my point? So then you have to remove it into the plain guide here. The next step is purely simple locking system. That part you know, where they put the nail and the impacts of the nail. Few things are there. The impacts on of the temple. Impacts on a length you have to measure. How to do the measurement you know. with the help of two techniques. One is indirect with the help of the guide wire. That also going to help you. One point. Number two, by the direct technique, by the help of Siam to know the length. Learn the length. ठीक है sir? Give of the length and you measure the length with the help of your Siam, or you can take the help of the guide wire to guide you. Yeah, this is the length I am going to do. Then you have to introduce. Introduce always with the hand. Do not hammer it. As far as possible, hand force is much better than that of your force. So do not hammer it. Do not hammer it until you are landing in the tip. Do not hammer it as far as possible. So you try to do the negotiation with the hand. You can do rotative movement also, but try not to hammer it initially. So until you are in the landing end point and you are coming, then you are going to hammer it otherwise. Yes sir? So do not hammer it. So locking system, next is locking system, you know, lock there to minimum. Now where to, it is a static one or dynamic one? What is the advantage of disadvantage of this? Static locking. So which one is static? Which is locking?
This one static, this one dynamic.
Acha, dynamic. If it is dynamic there, where it should be the screw? Show me. What should be the position of the screw? It is positive. Correct. So what is the advantage of the flexor is here? So now while you are doing the dynamization, which screw you are going to remove?
Static.
So this one or this one? This one. So if you are removing it, and what is the principle? What are the principle? Can you do the dynamization in distal fragment? Yes, you can. Longer fragment. This side. One other principle is there, longer fragment. If the fragment fixer is here, then you do the dynamization here. But as such, the nail design is itself as a dynamization technique. Dynamization. One thing that after doing rimming, the proximal rimming is important. What is the size of the proximal rim? Because this size is bigger. 14 size. So you have to be. So that is why you are bigger and should be used for the proximal rimming. So this 14. Okay, sir? So it is, so that is important. Otherwise it will be difficult for to negotiate this part. So that is why after doing the rimming, you have to go for this here. So the proximal rimming. Sometimes people used to go beforehand. That makes it easy. Or you start doing it. But you can finally have to make the proximal part bigger. Otherwise it will be difficult for to negotiate in it. Okay, sir? You know the other things, locking system. So there are two types of this. This system is a bit good. So you have to beforehand, before putting the interlocking, you make it sure that I am in the right track. What is the meaning of this? Look out. You put it there. Hold your piston.
For this hand, this is the jig.
Jig for what?
Jig for this thing, sir. This is for DFN, sir.
This is for PFN.
DFN, sir.
DFM.
Okay. Tomorrow too. And tomorrow also people used to come with this sort of device. This is for PFN. Okay, no, we are talking about, okay, put it there. Then how do you do the compression? Suppose you are distracted. What do you do? What do you do? What are the techniques to have a good... finally, after distal locking, you have seen that there is a flexor gap here. What is the technique to compress it? One, then you remove the flexor. One point is removed. One flexor which you are applying there, you will remove it. And even one can push it to some extent. People used to strike it there also. Otherwise, you have to strike it there with the help of your hands. So you have to have good contact between the two. Otherwise, it will be fail. But this technique is not applicable for committed flexor. Committed flexor, if you are doing it, you may shorten the limb. So here in the committed flexor, basic principle, you maintain the length and also rotation. Length and rotation. These are the important things. দিয়া যাব আচ্ছা এনে